Hi, and welcome to another edition of OrthoCarolina's monthly webinar series. I'm Dr. Brian Curtin from the OrthoCarolina Hip and Knee Center, and tonight I'll be talking about opioid-free total hip arthroplasty. This is being live streamed on our Facebook, LinkedIn, and YouTube platforms. So please don't hesitate to ask any questions, and we'll try to get to as many of those questions as we can, time permitting. I've been at OrthoCarolina now for about 14 years. I did my final training here, my fellowship, and then went away to Medical College of Virginia for 2.5 years. And then came back, and I pretty much do primary hip and knee replacement as well as revision. So when they go bad or have complications, we take care of them as well, and I do a little bit of trauma as well. I have 3 kids, 2 dogs, 1 cat, and a lovely wife that allows me to do this in the evenings to help out OrthoCarolina and spread some education to our community. So without further ado, let's go ahead and get started with our topic for tonight. So this all starts with our Carolina's opioid reduction effort. And I'm going to try and go through sort of the why as to why we put this in place, a little bit of the backstory, and then the current core hip study, which is the Carolina's opioid reduction effort study, and how we designed that, and then the results of that study, and then future directions, where we're going with this. Next slide. So I don't know if anybody's read the book Start With Why by Simon Sinek, but I'm going to try and kind of give you the basis of why we're doing what we're doing. Next slide. So the opioid epidemic, many of you have probably heard about this, and if you really look at the data over the last 23 years, overdose deaths involving prescription opioids have continued to climb and are typically around 16,000 to 17,000 per year at this point, and still slowly climbing. Next slide. And the problem with opioid prescriptions is they lead to other opioid overdose deaths. So people start with prescription strength opioids, and then they move on to cocaine and heroin and methamphetamines and the various other things that you can overdose on as well. If you really look, in 2023, we had over 81,000 deaths from opioids, and that actually surpasses the car accidents and yearly death tolls now. It's a big problem. Next slide. It's an iatrogenic problem, meaning it's something that we cause. It's related to the illness caused by medical examination or treatment. And half of all the opioid deaths that we see are actually from a prescribed opioid. 75% of the ER visits that we see for opioid overdoses are from diverted medications. And when we say diverted medications, it means grandma gets a prescription for her total hip or total knee replacement, and her grandson, Jimmy, goes to the medicine cabinet and decides to take that opioid and have a party with his friends and gets in trouble and ends up with an overdose. So that's what they mean by diverting medications. It gets into the wrong hands, and the wrong people are using it. Next slide. So if you look at this it's kind of a heat map starting in 2003 all the way down to 2014 in the bottom right corner, and you can see as it gets more and more red, those are the number of overdose deaths across the country. And you can really see that sort of the Rust Belt, the Southwest, even little pockets within North and South Carolina, as well as down into Florida, have really picked up in the last 20 years in terms of drug overdose deaths. Next slide. And this is our problem. If you really look, the U.S. makes up about 5% of the global population, but we actually account for 75% of the global prescription opioids consumed. So we're the ones that are using most of these medications. Next slide. And North Carolina is not immune from this. North Carolina is home to the #1 worst city for opioid abuse. And we have 4 in the top 20, with Wilmington being #1, followed by Hickory, Jacksonville, and Fayetteville. And these cities really have a problem with opioids, but it's not just these cities, it's all across the state. Next slide. So why are these medications so addictive? These are 3 different organic chemistry models of 3 different medications. And if you hit the next slide. No. Can you go back? Well, the one to the left, this should uncover these red boxes, but the one to the left is codeine, and the one to the right is oxycodone. And there isn't really much of a difference between these molecular structures, but the one in the middle is actually heroin. And I actually tell a lot of patients that the narcotics that we prescribe you are basically legalized heroin. So they're very addictive, and there really isn't that much of a difference between them. Next slide. So why are these medications so addictive? Well, if you look, 50% of patients that are taking opioid medications, i.e. painkillers, up to 3 months after surgery are still taking them 5 years later. So if you don't get off of them in the early phase, you can get really hooked on this stuff, and it's very addictive. It's bad or worse than cigarettes and some of the other things that we consider very addictive. Next slide. So how did we get here? Next slide. Pain specialists for many years said opioids were okay, that there was no ceiling dose, there was no limit on duration, and a lot of the pain advocacy groups kind of lobbied medical boards and such to make these medications more accessible to patient populations, and there was no real stigma on prescribing these. Next slide. The other problem is that we made pain the fifth vital sign. So nursing staff basically had to record patients' pain on a routine basis. And if you weren't managing patients' pain appropriately, then you ran the risk of losing your accreditation with the Joint Commission and various other healthcare groups. So there's a real push within healthcare to make sure that pain was well controlled at all costs. Next slide. And then there was some questionable stuff going on by some of the pharmaceutical companies. They were basically doing some false marketing and not being completely truthful with the American public. And a lot of this stuff has come to court in the last 5 to 10 years with the makers of OxyContin. So they didn't help us much either. Next slide. And JBJS is the Journal of Bone and Joint Surgery, which is sort of the main orthopedic journal for orthopedics. And they've actually come out and said that opioid abuse is now a nationwide epidemic. And the question is, what are we doing about it as orthopedists? Next slide. So we came up with the CORE project. And the initial aim was to identify clinical pathways that minimize or even eliminate the use of opioids so that patients can recover from surgery comfortably and safely. We needed to find alternatives to the opioids that we've been using for the last 20, 30 years to prevent pain in these surgical procedures. Next slide. So the solution, we needed a novel approach to pain management in a surgical patient. Therapies needed to be targeted at multiple facets of pain management. First was needed to reduce inflammation, decrease nerve pain signaling, and then provide a local nerve blockade at the time of the surgery for immediate relief. And we did all this in consultation with our anesthesia team that worked very closely with us to make sure that we were all on the same page. Next slide. So we came up with a novel opioid-free pathway. It included preoperative education. In preoperative holding, they got a certain bunch of medications. Intraoperatively, they received a certain medication group. And then postoperative recovery was very big on ice, as well as ketorolac, IV for 1 dose. Next slide. So they got a scheduled regimen on the floor, and then on discharge, they all got the same medication prescriptions as well that did not include any opioids. Next slide. So all of these folks were involved: our OrthoCarolina Research Institute, OrthoCarolina, Atrium Health, and then the Duke Endowment was actually the entity that provided much of the funding for this research. Next slide. So it's a comprehensive initiative. First, it wasn't just setting this protocol in place. There was a lot more that had to go into it. We needed to raise awareness, patients, providers, hospitals, and even the insurance payers. We wanted them to know that we were doing this and get everybody on the same page. So we had 3 main study questions. Can an opioid-free multimodal pain management pathway provide patients with a safe and predictable alternative to conventional opioid-based pain management regimens? Number 2, is there a difference in rates of complications, side effects, and overall satisfaction between the 2 groups? And then what are the barriers for enrollment? Next slide. So we had a large-scale prospective, meaning looking into the future, enrolling these patients for this study, randomized controlled trial, meaning patients were randomized into either the group or the study group. And then each of our subsections then picked a procedure that they felt that they could do with this protocol for a various list of surgeries that they typically perform. And the Hip and Knee Center picked total hip arthroplasty. We had our knee arthroscopy, our sports partners. We had bunion surgery with our foot docs, CMC arthroplasty with our hand surgeons, and even our spine docs wanted to do some cervical discs infusions with this protocol. So it was a all hands on deck, all the OC physicians chipping in. Next slide. So our study design, eligible patients were approached at the time of their surgical enrollment. So we saw them in the office and we had this discussion with them, and then they were actually randomized 1 week prior to their surgery by our research staff. So I had no control over which arm they went into. Patients that weren't willing to be randomized were assigned to our observational cohort, and we looked at their data later. Next slide. So our intervention group, basically everybody got the exact same thing, except the intervention group got no opioid prescriptions to go home with. Next slide. So our results. Next slide. Demographics, this is a busy slide, but you can basically look at this and see that the groups, the opioid-free group and the control group, are pretty much the same. The age, the BMI, male-female breakdown, smokers, previous use of opioids, all pretty much the same across the two groups. Next slide. So our results, our primary outcome measure was pain at 24 hours. And if you look at this, the opioid-free group, their average pain score at 24 hours was 2. The control group, meaning the group that were getting opioids and narcotic prescriptions, their overall pain score was 2 as well. So no difference in patient-reported pain scores at 24 hours. Next slide. Secondary outcomes. At visit 1, which was typically around 2 to 3 weeks post-op, we also assessed their pain rating. The control group had an average score of 5, whereas the opioid-free group were actually less, and this was significant, at 3. After that, when you got to visit 2 and 3, which are more sort of the 2, 3, 4 month visits or later, you see that their pain was down to 0 or 1, and that was not different between the groups. Next slide. Secondary outcome measures, we did look at pain control satisfaction and had no difference at 2 weeks and 6 weeks, so everyone was quite satisfied with their pain control. Their Hoos Junior score, which is like their score of how they're functioning, was no different for the two groups between 2 and 6 weeks. Their VR12 scores, which is a mental component, were actually better in the opioid-free group, which makes a lot of sense. You know, opioids tend to kind of mess with your head a little bit and give you a little bit of the brain fog. And so the patients that weren't on opioids had better mental scores. Constipation symptoms reported more frequently in the control group, again, because constipation comes with opioids, tends to bind things up and you don't get moving as quickly in terms of the GI tract. So more constipation in the opioid patients. And then no falls or delirium reported in either group at any time point. Next slide. So conclusions thus far, opioid-free treatment arm does appear safe and effective. Our randomization was effective into the two groups. Each one had an acceptable pain profile and an acceptable safety profile. We didn't see a lot of kidney failure or anything else from high-dose anti-inflammatories or any other issues with the opioids that we typically didn't saw before. Next slide. So interesting findings. Why did the opioid group actually have more pain? That goes back to that 2-3 week follow-up visit where the opioid group had a level of 5, whereas the opioid-free were 3. That was quite impressive that we actually had less pain. We didn't see any decrease in constipation after the 2 or 3 week follow-up visit. And I think that's just because most patients were getting off their opioids anyway. So maybe a little bit more constipation early, but long-term in the 1 and 2 month, it didn't really see much of a difference. Unanswered questions at this point. Is it procedure specific? Meaning if you have a posterior approach versus an anterior approach hip or various other things that we did differently amongst the various surgeons, could that play a role? Is the opioid-free clinical pathway actually superior, or is it just equal to the opioid-free, using the pathway? Are there any difference in clinical outcomes? We're going to look at this at about a year and make sure there's no difference in terms of clinical outcomes. Is it patient resiliency that plays a role? Some of these patients that actually wanted to be in this study, maybe they're more resilient and they just didn't want to take any opioids anyway, and or just better in terms of how they deal with pain. And then any barriers to enrollment, where we're getting different age groups or something that may have played a role. So we'll work through those details as well. So next steps, Core 2.0, we affectionately call this re-aim, which includes reach or more outreach to more of our more peripheral partners, effectiveness and adoption of these protocols into more of the surgeons within OrthoCarolina as well as our community, implementing these protocols and then maintaining them to make sure that once they're implemented, we continue to use them and continue to make them better with time. Next slide. So special thanks goes to the OrthoCarolina Research Institute that's been critical in terms of getting this study up off the ground, and the James Duke Endowment, which did most of the funding, and then all of the OrthoCarolina support that we received to run with this study. Next slide. Thank you very much from the Hip and Knee Center. And now we'll open it up to questions. All right, our first question is hip replacement now outpatient for most people? Also, are all OrthoCarolina surgeons doing anterior replacement surgery? Start with the first, with outpatient surgery. I'm probably about 60 to 70% outpatient surgery now. There are still some patients that need to be done in the hospital due to other medical problems and such, but it's definitely COVID even really kind of made this push to get patients more into the outpatient setting. They can sleep in their own bed. They get in and out, usually within 4 to 5 hours. They are into the surgery center and back out and going home. As for anterior replacement surgery, you are seeing a swing in the number of surgeons doing anterior approach hip, but we still have a lot of surgeons doing posterior approach. And if you really look at the data, they may bounce back a little faster with an anterior approach, but by 6 weeks, pretty much all the patients are doing the same. So I wouldn't necessarily chase the approach, but make sure you're comfortable with the surgeon and make sure they've got good outcomes. And I think you'll do well regardless of how your approach is done to a total hip arthroplasty. Next question, would the general approach to pain-free hip replacement also apply to knee replacement? I think knees are generally a little bit more painful and a little bit longer recovery than total hips. But we are already implementing a lot of these protocols with our knee patients because it does carry over in the way that we treat pain for both of these procedures. But I wouldn't promise anyone a pain-free total knee replacement because the knees do hurt a little bit more. There's a little bit more physical therapy and a little bit more involved. Next question. What can I be doing before surgery to be optimally prepared? Exercising, stretching, water intake, nutrition, etc. The big one for me is making sure you've got good upper body strength because you'll be using a walker or a cane the first couple of week or two, typically for a hip and a little bit longer for knees. Water intake is always important. Nutrition, we always want to make sure that you're getting enough vitamin D and make sure your protein level is high enough in that first few weeks after surgery. And it doesn't hurt to preload a little bit the first week before your surgery. Exercise is always good. You're going to put your body through a big surgery. We can sugarcoat it all we want. You're still having a major joint replaced. So the better shape you can be in beforehand, the better off you're going to be. Is there a safe way to get rid of crepitus in the knee after total knee replacement? This is relative because my hip replacement is the same leg as my knee problem. That might be a great question to get on a more personal basis in the office and find out why you're getting the crepitus in your knee after a total knee replacement. That may be related to scar tissue. That could be a lot of different things. There is a certain subset of the population that gets a total knee replacement that still gets a little bit of crunching and grinding in that knee due to scar tissue. But you typically don't get that after a hip replacement. We see it occasionally in knees, not so much with hips. Next question, what are the requirements and preparation steps for hip replacement surgery? Typically, you're going to see a surgeon, and whether or not you've been worked up by your primary care physician prior to that, or the orthopedic surgeon may be the first one seeing you for your hip and knee problem. Typically, you're going to be tried with all the conservative things first, your anti-inflammatories, braces, gait aids, various things. And you're typically going to want to see at least 3 to 6 months of conservative treatment prior to any hip or knee replacement. Then typically requirements prior to a hip replacement surgery. Typically we want you off of all nicotine products for 30 days prior to surgery. Typically a BMI of less than 40. Once you get to a BMI of 40, your complication rate tends to climb almost vertically. So we try to get you down below that BMI 40. We have some basic protein levels that we like to have, and a hemoglobin. Your blood levels need to be a certain level. And then for those diabetics out there, a hemoglobin A1C of less than 8 also reduces your risk of infection. So those are probably the big requirements and preparatory steps prior to undergoing your hip replacement. Next question. Are there less invasive procedures available? We sort of talked about the conservative options before that. You can also throw in some steroid injections. Not a whole lot other than what we just mentioned previously. In terms of less invasive procedures, there's not a lot you can do once the hip joint has gone bad and there's no cartilage remaining. your option at that point is pretty much a hip replacement. Partial hip replacements are typically used for patients later in life that still have pretty good cartilage in the hip joint and fall and break their hips. We don't typically do partial hip replacements for elective procedures for arthritis. So total hip is about what you're looking at if you've got an orthopedic hip. Are all OrthoCarolina surgeons offering opioid-free? We just rolled this out probably about a month ago, where now patients are being asked within their MyChart if they are interested in opioid-free care. And so if you opt into that pathway, then most OrthoCarolina surgeons will see that and in your chart, and will do everything they can to tailor your pathway to as opioid-free as possible. Some folks are a little bit further down that pathway of really engaging in opioid-free surgery, and some are catching up. But I think it's definitely a real focus within OrthoCarolina right now to help battle this opioid epidemic, and surgeons are getting on board. How has AI and robotics changed surgical techniques? I think we're seeing a lot more robotics in total knee arthroplasty as opposed to total hip. Robotics isn't quite as useful with total hip. We still use a lot of X-ray intraoperatively to help us kind of really make sure that our implants are where they belong. I'm not sure robotics can make us much more efficient on the hip side, at least currently. I think there's potential there in the future for them to play a bigger role. AI is not really helping us a lot in the OR yet. I think as we continue to gain more knowledge, especially from our robotic platforms that store a lot of this information, I think once that data is available, I think AI is going to be able to look at how a patient presents and sort of their baseline measurements that we get, and predict what size implants they need and where they need to be placed, and kind of give us a better knowledge base as to how to put in our implants. But right now, I think AI is helping us more in the office setting in terms of dictating notes and triage and that kind of stuff. But it's certainly going to make its way into the surgical OR soon enough. What is the typical recovery time and hospital stay for hip replacement? Again, about 70% of my hips are going home now the same day. Even a good portion that we do in the hospital that are not medically fit to go to the surgery center, whether they have really bad COPD or a heart condition like AFib. Sometimes I'll keep those in the hospital. But if they do really well the day they have surgery and they want to go home, we still occasionally will send patients home from the hospital with a same-day discharge. About 30% will stay overnight, and most of those will go home the next day. It is exceedingly rare for me to have a primary hip replacement now stay more than one day. So, and typical recovery time, I usually tell my hip patients that it's about a 4 to 6 week recovery on a hip, and 6 to 8 weeks typically on a knee. But usually you're pretty much doing most things you want to do by 3 months. By 1 year, I tell my knees that's sort of what you're going to expect. It's a full year to recover from a knee replacement, and I usually say about 6 months complete recovery on a total hip replacement, to the point where you forget you got a hip replacement. So those are your typical recovery times. How long does a hip replacement last, and what factors affect its longevity? Back in the 80s and 90s, we were getting 10 to 15 years on a typical hip or knee replacement. The plastic bearing was the weakest link in the system. I like to compare it to tires on your car. It's not the wheel on the tire that goes bad, it's the tread on the tire that goes bad. And that's the plastic in a total hip or a total knee replacement, is the tread on the tire. Around 2000, the plastics went to a highly cross-linked plastic, which made it anywhere from 100 to 1,000 times better than what we had back in the 80s and 90s. So we really don't expect implants now that have been placed since 2000 to wear out in less than 30 plus years. So I tell most of my patients over the age of 50 years old, I think it's the last implant you're ever going to need. And even younger than that, I don't really worry so much about putting a hip replacement in a 30 or 40-year-old now, just because the longevity of these implants has gotten so much better. What are the causes and solutions for leg length discrepancies or differences after surgery? This can happen for a multitude of reasons. Sometimes someone, before their surgery, they may have had a slight leg length discrepancy to begin with. It's not always possible to fully restore that. Sometimes a patient's soft tissues, once you do the surgery, if they're very lax, the hip that we give you is never as stable as the one that God gave you. And so we do our best to restore your leg length and the offset of the implant to get the soft tissue tension appropriate to keep your hip stable so that it doesn't dislocate or come out of the socket. And sometimes, depending on what we find intraoperatively, sometimes we have to make that leg a little bit longer to make it stable. And usually it's a couple millimeters to half a centimeter, somewhere in that ballpark. Occasionally it'll get longer than that, but exceedingly rare for someone to have a long leg length discrepancy after surgery. What are the issues with being hypermobile and having a total hip replacement? Again, sort of goes back to that last question that I just answered. In terms of patients that are hypermobile, you've got to have the soft tissues around the hip joint to make it stable. And if you're already very lax in terms of soft tissue balance and constraint around the hip, sometimes we have to make you a little bit longer or increase your offset, meaning sort of how far away the femur is away from the pelvis to tighten up the soft tissues. So hypermobile patients can be a little difficult sometimes to make sure they get stable. We also have some different bearing options that allow us to make that hip more stable right out of the gate with more based on the bearing itself as opposed to the muscles and soft tissues around it. Next question. What are the lifestyle limitations post-surgery, and can activities like running or horseback riding be resumed? I don't limit my hip replacements at all. I let them do whatever they want. My knee replacements, I tend to tell them no high impact activities repetitively. Don't let them run marathons. I do have a couple of patients that run 5Ks and 10Ks on knee replacements. But my hips, they do pretty much everything they want. I've got a patient that sends me a postcard every year that of him climbing a various mountain and various peaks around the U.S. with a heavy backpack on his back and does just fine. Running, you can run on a hip replacement. Horseback riding is certainly an option as well. I've got plenty of folks that ride horses with a hip replacement. So shouldn't be an issue. What is done before the surgery? Anesthesiology, injections. Are you partially awake during hip surgery? A lot of cases now are done with a spinal block. It's typically better for decreased blood loss. You don't get as much of the mental fog after the surgery with a spinal block because you're just lightly sedated, similar to what you would have like a colonoscopy. And if the surgery is quick, occasionally we'll still do general anesthesia at our surgery center because it allows that patient to wake up quicker and get up and get moving in the recovery unit faster to go home. But a lot of our hospital patients will be done under a spinal block, and it's a very good pain control. It usually lasts 4 to 6 hours, depending on what type of block is put in, sometimes shorter, which allows them to get up and get moving as well with physical therapy in the hospital. But it's good pain control, especially if they're staying overnight. Injections, we also do sort of a cocktail that we inject into the hip or the knee that lasts anywhere from 12 to 24 hours typically, that helps kind of numb up the soft tissues around the hip or the knee and helps a lot with pain control as well. So are you partially awake during the hip surgery? Again, similar to a colonoscopy, you're not fully asleep to the point where they have to put a tube down and breathe for you, but it's light sedation so that you're pretty much, you're not feeling anything or really aware of what's going on until you wake up. Is hip resurfacing a viable alternative to full replacement? So the only difference between hip resurfacing and a full replacement is that with a replacement, you typically get a stem that goes down the femur, which is typically about 4 to 6 inches in length. The problem with resurfacing over the last few years is that it's a metal-on-metal bearing. And there's been a lot of bad press and a lot of recalls and such with metal-on-metal bearings. That's how a resurfacing works. It's a metal-on-metal bearing. And if it's done well, it's a great option. But the data is pretty clear that it doesn't make a huge difference in terms of activity level or function, whether you do a resurfacing or a replacement. So I'm not a huge fan of resurfacing. It adds another potential variable into the process with metal ions and the potential damage that those can do. But if you've got a surgeon that will do it and does a very good job, then it's certainly an option. But I think hip replacements have definitely come to the forefront, and the vast majority of patients are getting full hip replacements at this point. Well, thank you for attending. I appreciate all the questions. This is a wonderful OrthoCarolina live webinar, and the recording will be posted on our social channels. So if you missed the section or you want to hear another part of it over again, you can certainly find it on our social channels. If you'd like to schedule a visit with an OrthoCarolina hip or knee surgeon, the easiest way is to go online. You can pick the time slot and day that you'd like, or you can call, but probably easiest to go online at orthocarolina.com. Thank you and have a great evening.